sit since it's so big. So yeah, my presentation is about empiric antibiotic treatment for common surgical presentations. Kind of stemmed from Dr. Chang. He asked me about empiric antibiotic treatment for an appendicitis patient, and I was like, I don't remember. So I wanted to do this for kind of selfish reasons, since I'm interested in pursuing surgery on my fourth year rotations. It'll be a good knowledge background to have and hopefully impress either residents or attendings. Hopefully it's something's useful for you guys too. So I'll first start with biliary colic.
Trauma, level 2, ETA, 5 minutes.
Holisticity.
Code trauma, level 2, ETA, 5 minutes, stat. Code trauma, level 2, ETA, 5 minutes, stat.
Alright. So, I put on this page all the indications. So you have a couple different situations when you're considering like biliary colic or cholecystitis. So that's why it's important to differentiate the two. One, if it is just colic, there's no indication for antibiotics because whatever is blocking it will pass, and there won't be time for infection to brew inside the gallbladder. All antibiotics are definitely needed if you have complicated patients or your patients are frail. So complicated patients include things like gangrene, necrosis, rupture, or emphysematitis, cholecystitis. So part of the problem is you can't really tell if any of those things have happened based on the imagings we have available, right? You can't really tell if we have gangrene on CT or things like that. So if you have a patient that looks concerning for acute cholecystitis, antibiotics are generally recommended, and most people do them. If you have even uncomplicated, but you're worried that the patient might be older or is diabetic or immunocompromised, go ahead and start them.
Sorry.
And you can always stop them after surgery, unless you read the operation report and you realize that there was a lot of potential peritoneal contamination. Then they might want to continue going forward. So one thing that's interesting about most surgical cases is that the anaerobes or the bugs that could be causing infection are relatively similar. So I put a chart on the PowerPoint that describes the various antibiotics. But I'll do it after I talk about appendicitis because it's basically similar coverage that you're looking for. So the most common bugs, obviously E. coli, right? We're talking about poop. Enterococcus, Klebsiella, and Enterobacter. So if you prescribe by thinking, okay, what do I need to cover? These are the big ones that are most commonly associated with intra-abdominal infections. Interestingly enough, I found a trial about appendicitis. It's called the CODA trial. It's not as fancy as the HOPE trial. But it was done this year and was trying to compare antibiotic therapy or surgery for appendicitis. So it was a little interesting because at 30 days, the antibiotic group was considered non-inferior, meaning they felt clinically the same as people who got their appendix taken out. So like they come to the hospital, you're like, oh, just take these antibiotics, and they would just go home. And their length of stay was approximately the same. They incurred fewer costs because they didn't go through surgery, but that was that. So they're like, well, can we just treat appendicitis with antibiotics? We even need to operate. But by 90 days, 30% of the people that received just the antibiotics needed an appendectomy because of reoccurrence of the problem. And interestingly enough, that those people that received antibiotics initially, went home and then came back to get their appendix taken out again, were associated with higher complications during the procedure. Complications being like, seeding the peritoneum with maybe fecal material, or that there was abscesses, longer durations under anesthesia, increased bleeding, increased post-operative complications like ileus or things like that. There were too few deaths to say if there's any difference between the groups in terms of that statistic, so they didn't report anything on that, but it was clear that there was higher rate of complications in the group that received antibiotics and then came back later for recurrence of the symptoms. And then another special indication, if you have a perforated appendix, most people treat antibiotics first and then wait to do the surgery until the initial infection and clinical picture has subsided a little bit. So here are the antibiotics that are recommended. So on this side you have low risk community acquired, and here you have high risk community acquired. And there's actually another chart for high risk hospital acquired infections, but it was the same chart as this. So the same drugs that you would treat a high risk community would be used to treat someone who developed choliscystitis in the hospital or developed appendicitis in the hospital. So this one seems like it's more broad and more up to the clinician to decide which one to prescribe for. This one obviously is more narrow, and you see that it's mostly what would be considered more of the higher end antibiotics, things that have less resistance, considered your big guns. One thing that we were talking about earlier today, though, that I hadn't known was that if you have a younger patient with gallbladder issues, you might want to avoid some of the cephalosporins because it can cause biliary sludge and potentially worsen the problem that could be going on.
Hello?
What?
Is Chapman going anywhere?
So another common presentation for surgery is skin infections. And there's actually a very kind of clear-cut procedural plan to follow when you have a skin that may be concerning for necrotizing fasciitis, because that's when you would call surgeons, right? So if you have any clear signs that there's necrotizing fasciitis, the best plan is to obtain cultures, call surgery, and get them to get debridement immediately. If there aren't clear signs of necrotizing fasciitis, then you can start antibiotic therapy and monitor for any of the clear signs. So some of the clear signs, the two big ones are crepitus or gas producing, or rapid progression of the clinical manifestation. So if they came in, they had red swollen leg, and then the next day it's spread even farther and you touch it and there's crepitus, then that would be oh, we got to step it up and obtain the surgical consultation. And then after that, it gets a little bit more blurry. But that's kind of the basic first thing you have to do is okay, is this it or is it not? Because you don't want to delay the time that they need to be in the OR. I have a personal example of this. When I was on my surgery rotation, a man presented to an emergency department in Big Bear with cellulitis of the foot. And so they started him on antibiotics. And while he was there, he got stomach problems. He got distended, and so they took an abdominal CT and thought he was too sick for their care, and then sent him to Arrowhead, where I was at. They get this patient, and they have no idea that the main concern that he was brought to Arrowhead for was this GI problem, that he was obstructed or not having bowel movements and stuff like that. And so they were looking through the CT and they saw some gas, and they said, "What is this?" And it was in the fascial layers, not in the belly. And so they go and look at the patient, and he had what looked like necrotizing fasciitis all through his whole leg, up from his foot up into his leg. So they go to the OR and they actually followed it into his abdomen. So because in the situation they hadn't, immediately said, "Oh, this is neck fasc, we need to get him in the OR," when it was just in his foot, it ended up spreading up into his abdomen. And then he, had a much poorer prognosis after that. So these are basically the main treatment protocols recommended. If you're concerned that there's necrotizing fasciitis, you want to go big, you want to get the most broad coverage you can, and up-to-date recommended carbapenems.
Any preference for meropenem or ertapenem?
It didn't mention that.
How much is she eating right now? Or you average?
They did mention the specific dosages. I didn't include it here, but yeah, I'm not sure. They said either are equal though. You could do Peptaza with vancomycin and clindamycin.
And what's the explanation for added clindamycin to that?
So clindamycin, they were saying, has antitoxin properties. So the two that you're worried about are Staph aureus and Strep pneumo. Both produce
Yes.
I thought it was Staph pyogenes. Sorry. So Strep.
So we'll just continue to
Staph aureus and Strep pyogenes. They both are anaerobes. They're both bugs that produce toxins that cause, like he said, toxic shock syndrome or scalded skin.
By the means of
clindamycin has been shown to prevent those toxins from working. I didn't look up the mechanism, but that's the reason why you'd add it on, because if you have vancomycin, you're already having MRSA coverage. But so this would be specific if you're concerned for a necrotizing fasciitis. If it was just cellulitis, I don't think you have to be worried about the toxins as high.
Still.
Okay. Still.
Mm-hmm.
So yeah, those are the 3 situations I looked up and gathered data for.
All right. Cool. So how would you think a patient that cholecystitis is very common? How would you think this patient is actually having something that could be a major cholecystitis versus just a localized local peritonitis cholecystitis? What would make you suspect a bigger picture that will require antibiotics?
Yeah, and that's the debate that they're having, right? Is because pain as itself can be an indicator, but people present with very different pictures. Some have high pain and they have like a very benign when you actually look at the gallbladder or look at the appendix, it's benign. But some people have low pain, you go in and it's perforated and it's like gangrenous. And so pain has not been proven to be a good indicator. But like overall, there are you can use your clinical exam on their abdomen. Someone who has more symptomatic cholelithiasis, they're going to have the very acute pain, Murphy's sign, but the rest of their abdomen is going to be pretty benign. But the more complications you get, the more the rest of the abdomen will be less benign. You'll have guarding throughout.
Rigidity.
Rigidity.
So when in doubt, antibiotics.
Yeah.
And then you can use your markers, right? Leukocytosis, anemia, damage to other organs, lactic acid.
Yeah.
Of course, the physical exam for diffuse peritonitis versus just localized peritonitis. Yeah.
Now, I want you guys to remember that infections don't necessarily correlate with very high serologic biomarkers. What I mean by this is we've had several cases of endocarditis with normal white counts. They just have malaise and just don't feel well. And if you consider endocarditis one of the things you must catch, white counts stone cold normal.
That's crazy.
Every blood culture was positive. Well, I mean, it's smoldering, of course, as opposed to most kinds of cholecystitis and appendicitis, I suppose. People tend to have very flamboyant presentations and stuff, so.
That is true.
Always follow up the operative report. Always. Some people miss, this was a gangrenous cholecystitis and discharge the patient without antibiotics.
Yeah.
Not a good idea. So follow up with. There's a reason why you have to ask the surgeon before you discharge a patient.
Yeah.
Yeah.
Have you ever heard of the APEX study?
Mm-hmm. And also follow up on pathology.
Pathology.
Because while normally stones or fecal lifts are the most common causes of appendicitis and cholecystitis, especially in older populations, it can often be cancer related.
To the other topic that you talk about the appendicitis and antibiotic therapy or not, or surgery, this is a thing that has been going on for so long, right?
Yeah, well, I'm pulling up the previous paper to what you.
So the CODA trial was the one that happened in 2020
with a large amount of patients. This one is somewhat smaller in 2015. So it's one of those things that is a lifelong debate because everybody keeps whining about like not wanting to do surgery, but every single time it turns out that surgery is always better. Like,
yeah, and then for a hospitalist, you think, okay, you have a patient with a lot of pain and it's like feverish and it has an obvious appendicitis on CT scan. You can do surgery and fix the problem in one day and have this patient back to workforce, back to school,
especially with laparoscopic,
right? Or you can start antibiotic therapy and pray for this to work based on your trial results. It will work, so the patient will stay here for 3 days, 4 days, waiting for it to work. But if it doesn't work, he will still need surgery with the possibility that it's being a complicated appendicitis. So we had both situations here, that surgeons fighting for not to do surgery, the hospital is advocating to have the surgery done.
Yeah.
It's at the end, it's a shared decision. Talk to the patient. No right or wrong, I guess.
So that's interesting.
Right. Surgery is always right.
Because I like at Arrowhead, because they have the residency program, I feel like they would never have an argument about that. It would always be like, oh yeah, we'll do it. Like, but because the residents, they're always there and they need the practice. But maybe here at a private practice, if they appendix.
Appendectomy is usually pretty good about taking to surgery, in my opinion.
Yeah,
it's cholecystitis or biliary colic becomes trickier because we always think it's cholecystitis, and the surgeons always think it's biliary
colic.
It ends up being necrotic cholecystitis. Okay.
So I suppose there's a bickering point there. So
okay.
Oh, okay.
Another interesting thing they said. I don't know if this one mentioned it at all, but because I brought up the fact that if you had a perforated appendix, the current way to manage it is not immediate surgery. You do it after the initial inflammatory process has subsided a little bit, meaning like there's a walled off abscess or something like that. They said that's the case unless you do it laparoscopically. They said laparoscopically still has good results no matter when they do it. But when I read into the paper, they said of the people that did the laparoscopic during the acute phase of perforated appendix, more than half were converted to open. So that's kind of a not good complication. So
I absolutely agree.
So it still is better to wait, even if you're a very skilled laparoscopic surgeon.
I want to start out by saying I don't actually know the surgical papers as well. I only know New England Journal of Medicine, where it has every single paper I pulled up from New England Journal of Medicine.
Hey, the CODA trial's on New England.
Hey, look at that.
See?
But hey, in general, look, I actually really appreciate you going through this because I have a whole bunch of questions. Now, I suspect that the borderline pediatric population might be slightly different because it seems like
these are all in adults.
The pediatric population, we tend to have a greater urgency to take the surgery for reasons that remain opaque to me. Mm-hmm. That's what it seems like to me, at least. Anyways, all things said and done is thank you so much. I mean, so in general, I think that on the two charts, the one medicine in common is zosyn.
It was on both.
So I suppose that for my clinical management,
just
so you know how the one thing that you told me about the other day, how they were saying that when you have appendicitis, you have to cover for Pseudomonas, I think is what they told you. According to UpToDate, that's only if it's a high-risk patient.
Okay, so not in a pediatric patient or something?
Empiric therapy for high-risk community is when you have to worry about Pseudomonas.
Yeah, absolutely. I just remember reading somewhere about like appendicitis and it was in children or something where you